Today we have a very important person as the moderator, none other than Dr. Kenneth Ellenbogen. And it is at a decent time that we have woken him up. So it's not too early for him. And without wasting much time, I would, after just two more seconds, I would just hand it over to him. First of all, Dr. Angelo Oricchio will not be joining us because he is down with acute labyrinthitis. So it is all up to Dr. Zanon now to take the debate forward. And I must thank Dr. Deepak Padmanan for conceptualizing such a beautiful program. My heartfelt thanks to him. Without him, this would not have been possible. So with this thanks, I request Dheeraj to mute everybody, please. Dr. Ellenbogen will kindly unmute yourself and the speakers can unmute themselves. Thank you so much. Over to you, Dr. Ellenbogen.
Thank you very much. Dr. Rohr, thank you for inviting me to chair this great meeting. Although Dr. Oricchio says he has labyrinthitis, I'm not 100% convinced because I suspect he was afraid to go up mano a mano with Dr. Zanon on this very important topic. And that is, what do we do with patients with moderately impaired ejection fraction, dilated cardiomyopathy, complete heart block? Is it CRTP or selective conduction system pacing? Why fix it if it ain't broken? Well, we're going to hear from Dr. Zanon why conduction system pacing is the way to go. Thanks, Dr. Zanon. It's a pleasure to have you here. Dr. Zanon is in the Arrhythmia and Electrophysiology Unit at Santa Maria della Misericordia General Hospital in Rovigo, Italy. Please unmute yourself. We look forward to hearing your comments. Dr. Zanon. Unmute yourself, please.
Sir, you have to unmute yourself. Dr. Zanon, please unmute yourself, sir.
Okay.
Yeah, great.
So I'm good ready. So first of all, thanks very much. Thanks, Dr. Ellenbogen. Thanks very much to my friends in India, Vanita, which is the representative, the secretary of the Indian Arrhythmia Society. And I have also my friend, Dr. Sharma. It's a very pity that my friend Angelo don't want to fight with me. I'm not sure he was afraid. He's too a giant to be afraid. I mean, even always when I did some of this competition, my first slide is when you compare his versus CRT is always Davide against Goliath, and of course we are always, but we try to do something. And in particular, this topic is quite intriguing because is not really the clear class 1 indication of CRT, which of course there is so a large amount of paper published and all the guidelines is towards CRT. But we try to go through and explain something. So those are my disclosures. But another disclosure is that I'm also pro-CRT, because if you can see, I was an author of quite enough paper on CRT that were speaking on also pathophysiological way of this, from technique, the use of telescopic, up to the determination of electrical delay, also many on the effect of multipoint, also looking at the contractility. But on the same wave, another disclosure that I have been involved in many years also in his bundle and recently also in left bundle pacing. So if we want to see against Professor Auricchio, which is a very large amount of papers on CRT, 100, but on his bundle, really zero. And from my point of view, I think to be more equal on those two techniques. But from this point of view, I really think that CRT and his, of course, in the joke of a controversy, is nice to understand which are the reason for one and the reason for the other. But I think that, of course, are really complementary and is much more tools that we have to treat better our patient. And so if we want to really treat better our patient, I think that we have to completely understand which are the pathophysiological figure that are inside each of other technique, understand which are the real problem of our patient, and look which is the best approach for each of our patients. But going on this debate, which is ejection fraction 45, there is no clear indication from guidelines because what the guidelines, the US guideline of 2 years ago say is that in 2A indications say that patient with AV block who have an indication for permanent pacemaker and a ventricular pacing more expected more than 40%, that means this our patient in this case because it's an AV block, but an ejection fraction which is this gray zone of moderate depression, which is 36-50%, and is reasonable to choose pacing methods that maintain physiological ventricular activation. And the guideline pose on the same level CRT or his pacing. So from this American US guideline, I would say that CRT and conduction system pacing is one, and the ball in the middle of the field. And also, this is in the case, in our case, which is 45%, but also in patients who need pacemaker without specifying if there is depression of ventricular function, say that to maintain physiological ventricular activation, again, his bundle pacing may be considered. But moving on, the European guideline, which is more recent, as you can see here, August of the last year, there is a class 1 evidence C, so is expert consideration. In case of tachycardiomyopathy due to supraventricular, mainly atrial fibrillation, that can not be ablated, undergo the classical indication of ablate and pace. And for sure, ablate and pace in patients with narrow QRS, what is our best intention is to maintain the narrow QRS, and so preferably go for conduction system pacing, his or left bundle. But doing in many years that I'm doing this procedure, and now that the field of conduction system is opening, I think that the importance of imaging is growing and growing. Why I'll say this? Because this is too clear example. Look, on the left, this is a man, 56, ischemic cardiomyopathy with a very depressed ejection fraction, 25, already undergo cardiac bypass surgery years before, and now came in our coronary unit for an acute MI with a complete AV block and also has non-sustained ventricular tachycardia, but with narrow QRS. So what to do? Was a clear indication for pacing, for sure, but also for ICD because of the depressed ejection fraction, because of non-sustained ventricular tachycardia. But also we need, because of this very depressed ejection fraction, we need to go for a very specific physiologic pacing to avoid detrimental effect of RV apical pacing. But because look here, because of the myocardial infarction, this septum is it was only 5-6 millimeter and completely scarred. So how can we think to screw something here? And I think that because we had these images, so we decided to first try to go for his, and in case of not good parameter, to go directly to see the classical BIV without looking for a left bundle. And I think that in this case, imaging was helpful for us. And to end the story, this patient, we couldn't have a satisfactory his, and we go for a classical BIV CRT. On the right side, on the contrary, this is a friend, is also a colleague. And as you can see, it was a 59 with left bundle since many years, but in near class 1, with the depression of ejection fraction, 30% echo and MRI 21. Already have ablation of premature ventricular contraction. So a clear indication for ICD. But look, this is an MRI. All this is anterolateral, lateral, posterior wall, which is all this wall is what is considered the target site for CRT. So how can you go there? And in fact, this patient, as you can see here, as this is the left bundle branch 180, and this is the perfect east bundle pacing with narrow QRS. Now this colleague is in a very good clinical status. So it's important to guide to drive our therapy to see for imaging mainly echo and MRI. But speaking on physiologic pacing, I had in mind what the physiologists say. Physiologists say that if you want to keep synchrony or avoid synchrony, and if we want to resynchronize, we have to go for some point which are crucial. First of course, is avoid apical right ventricular pacing, and I think there is no doubt on this. But second, is better to prefer endocardial activation compared to epicardial, because there are many insights that say that the normal activation is from endo to epi. Then I would like to choose ventricular activation through the normal East Purkinje system. And then, because as you can see from those very white hold figure that show us how is the normal activation? The normal activation is rapidly go through the His and then from the apex to the base, and then narrow the QRS. So all these points say that probably is better the conduction system pacing. But which are the clinical benefit? The clinical benefit we can distinguish in patient with sinus sick disease, AV block, or atrial fibrillation with low conduction, in which we can prevent the ventricular dysynchrony and preserve left ventricular function. We prevent the PICM, which is the pace-induced cardiomyopathy. And all these can reduce heart failure hospitalization or combined endpoint or heart failure and death. And in case of those patients are patients with preserved conduction, but in case of a patient with bundle branch block, is a rescue strategy for patient with left bundle, which at the moment in patient with depressed ejection fraction is class 1 indication for CRT, but because it's not a clear indication patient with right bundle, is a promising option for patient with heart failure and right bundle. And again, this is a classical example of left bundle branch with notch. There is all the Strauss criteria, as you can see here, but this is a wonderful result with his spacing, in which is also selective because there is a spike and a very small isoelectric, because we really, in this case, treat or cure the conduction disturbance, is in my mind, in which we, if I look back all the 100, probably more than 1,000 CRT I performed in my life, I never observed such a result with the standard BIV procedure. And this was a quite old explanation described by Narula years ago. This is quite is a new slide, but it's very, very famous because it's the first insight of the mechanism of the conduction disturbance. And what is fundamental for me is understand that there are two types of disturbance. One is the block at this level, and the other one is that there is a slow conduction. So approximately 1/3 of the patient who has intact Purkinje conduction, activation, sorry, but the activation is slow. And so it's clear that if we pace at this level, we cannot improve the activation. And this is the clear mechanism. There is a slowly conduction compared to the normal conduction. Here there is a block. In this case, we can recruit and we can treat and we can cure the patient. Of course, in this kind of patient, we cannot do some good result. Synchrony is preserved, and this is quite a very explicative figure from the UK group, from Imperial College, in which they show the difference from intrinsic, selective, non-selective, or BIV. Intrinsic, selective, non-selective, as you can see, the left ventricular activation is of the same color. That means that we have a normal activation. In case of BIV, the activation is from two sides, is not homogeneous. But going inside the mechanism of breath synchronization, I want to show you some real examples. So this is a patient we did in our center, and this is 81 years old, ischemic. Indication, as you can see, for CRT because of 35 of ejection fraction, left bundle, very large QRS. And so this is the baseline left bundle. We could pace with selective large, and also we can pace with the higher output with selective narrow, as you can see here. What is this? This is the electrical signals that we can record here. This is the His lead, and this is a quadripolar in a lateral, proximal, and distal. So we can measure the ventricular delay, that that the so-called QLD. Look here, lateral distal, when it's paced with the selective large, the QLV is more than 200. What happened, which is more or less the same that baseline, because we have to add 50 milliseconds of this HV interval. So 160 plus 50 is exactly 210. But what happens when we narrow the QRS with selective narrow? Look, the QLV is 120, but if we subtract the 50 of HV, the QLV is only 70. And the difference between this and this is 90 milliseconds. That means that we have resynchronized by 90 milliseconds the left ventricle. And it is, in my mind, one clear and very good explanation of why his pacing could resynchronize as well as by the left bundle. But another paper by our friend Sharma is this one. Look, look, they had in 1/3 of those patients in which the ISP was in failed or rescue in BIV non-responders. And this incredible result in which then, of course, as expected, narrowing of QRS, but also increase in overall LV function in all patients, both with very depressed ejection fraction or in patients with mild depressed ejection fraction, like the patient of our debate, which is 45. So it's exactly this patient. And the average of those groups is that goes up to quite normal ejection fraction. Again, resynchronization, patient with the left bundle, this is intrinsic, this is BIV, and this is bundle that's correct. Again, that's the example I show in which the electric activation is perfectly short, and also in this case is all green. So the ventricular activation is shortened compared also to IV. And this paper, which is recently published by a cooperation between Chinese and friend from US, is in patients with non-ischemic cardiomyopathy. And apart from the threshold, what is worth to know is that the mitral regurgitation, the cuspid regurgitation, at 12 months, there is a reduction, a significant reduction, but also if you look at the increase in ejection fraction at 6 months or 12 months, so we from a very depressed 32 goes up to quite normal in this group of patients with non-ischemic and left bundle branch pacing. As you can see in this photo, this is a left angiography, left oblique angiography, and this is the CT scan that show how the left lead penetrate, the lead penetrate the ventricular septum and is on this side of the left ventricular. But again, if we consider the case that Dr. Vanita asked me to debate, is this case. This is a young woman, 50 years old, left bundle, QRS duration 150, prolonged HV with AV21 paroxysmal, so clear indication for pacing. And this is the result. This is a normal, it's a completely normal QRS. We really treat, in this case, our patient. And also, we have a clear effect on the synchronization. Look, in a spontaneous LB, you don't need to be an echocardiographer to understand that every segment of the ventricular, of the left ventricle goes from a different side, and this is a perfect coordination. But also another important finding is that the mitral regurgitation, which is important for effort dyspnea, is reduced by selective his bundle pace. So in this case, we can say that his bundle means really cure or treat the conduction disorder. One of the, I'm going to the hand, and just to compare the different effect in patient with approximately indication, so it's not really below 30%, it is below 30%, 40%, left bundle defined as Strauss criteria. This is again a collaboration between Chinese and US group. So the story is that there was 46 patients with BIV, and what is worth to note is that there is 7 in which the CS lead could not be implanted, so 7 is more than 10%. The East bundle was attempted in 91, and also is worth to know that due to probably not a good electrical parameter, was satisfactory only in a little bit more than half patient, 47. And so the other 32 went to left bundle pacing. The prevalence was a non-ischemic cardiomyopathy, very wide QRS duration, 160, 170. The baseline ejection fraction, 30%. Functional class was advanced, 2, 3, 50% in 3. And look here, the procedure and fluoroscopy time are incredibly comparable, because was the most prolonged was for the standard IV, 2 hours, with a fluoroscopy of 10 minutes, and his fluoroscopy is comparable with his bundle, little bit less total procedure time. But if you look at fluoroscopy in the left bundle pacing, is only 5 minutes and less than 100 minutes for. But what is also worth to know is the difference in increase in what? In clinical and echocardiographic parameter. Look here, clinical outcome, the baseline of the NIA class, you can say that NIA class is not so rigorous parameter, but it's something that exprime the clinical status. So look here, the his bundle group goes from approximately 2.8 to 1.2, and left bundle 2.8 to 1.3. Also, there was an improvement with the standard by V, but from 2.8 go to 1.9, and this difference is significant difference between, so is better from the conduction, which is represented by his and left bundle. But also, if you go for echo parameter, that means remodeling is better, and there is a statistical difference compared from by V, which is in the green bar, compared to his or left bundle that show the same improvement. And also, if you go to this group of patients with at the final ejection fraction more than 50%, that means most normalizing. So more than 2/3 of the patient in his or left bundle normalize the QRS compared to only 45% of patients with BIV. Last study, I want to show this presented by Pugal at the Rhythm Virtual. So this is a multi-center international with the inclusion criteria cardiomyopathy with the ejection fraction less than 50%. That means our patient, the patient of our debate. And as you can see, the echocardiographic parameter in all patients that were more than 300 successful were approximately 300, that means 85% of success and only 15% unsuccess. As you can see here, 85% was a success of this strategy. The procedure time is, we can say, procedure time is comparable with the previous study I show you. What is prolonged in this case is fluoroscopy, which is for me really too much, 20 minutes, sorry. In our practice now is very reduced. The complication means has to be the dislodgement is only 2.5, which is perfectly comparable to the traditional standard lead, and that's the outcome. The outcome, as expected, QRS duration goes down in both groups, in all left bundle pacing and non-left. NIA class improved, and improved also the ejection fraction in all groups. And the response rate. This is a well-known also that compare the slide that the study. The big problem is the tremendous crossover, not only in one versus one, but was bilateral. So 50% goes from his to BIV, but also 1/4 goes from BIV to his. There is no difference, statistical difference, but there is a trend towards a better result from his. Probably this is due look to the small amount of patient treated. So just this is the final, the open question or final thoughts is that are biventricular pacing and conduction system pacing equal? We really don't know. Is one superior to the other? We have to wait for a randomized trial. Are there any different clinical or electrophysiological conditions in which one technique is more desirable compared to the other? And which is the best approach if there is any in patient with a right bundle? I would say probably is his. And in patient with left bundle and coexistent intraventricular conduction delay, or in patient with intraventricular conduction delay, and patient with simple atrial fibrillation, and also in patient with induced cardiomyopathy, candidates to upgrade. Those are open questions. And finally, I will say that as our painter, Raffaello, show in this Scuola di Atene, conduction system is starting a renaissance of cardiac pacing, bringing implanting cardiologists back to the time of cardiac electrophysiology pioneers. Thank you for your attention.
Thank you, Dr. Zanon. That was a truly Renaissance-like overview. And I think Dr. Riccio is probably glad he has a little bit of vertigo right now, because he'd have a hard job refuting all the data you presented, particularly some of the newest data you presented. So thank you, that was great. And truly a fitting ending with that picture. So we're going to move on. Our next speaker, Dr. Sharma, Parikshit Sharma, a good personal friend and colleague who will talk about tempering the excitement for selective conduction system capture. Fools rush in where angels fear to tread. We'll see if he has some Renaissance pictures to sort of summarize too. Parikshit, got a hard act to follow.
I think Francesco has to stop sharing so I can share my slides. Francesco, if you wouldn't mind.
Yeah,
You need to stop sharing
Dr. Francesco will be leaving the meeting in some time because he has to go for the next meeting. So maybe we can thank him here only for his beautiful presentation. You have to unmute yourself, Dr. Elena.
Ken, I think Vanita wanted you to just quickly thank Francesco because he's going to be leaving soon.
Yeah, thank you so much, Dr. Zanon, for your excellent presentation. And thank you. Thank you.
Thanks, Francesco. See you soon. I wanted to start by thanking Dr. Ellenbogen for moderating this session. As you all well aware, Dr. Ellenbogen's one of my mentors and has taught me everything I know about electrophysiology, so I owe him a lot. So it's an honor for me to present here with his moderation. And I also want to thank Vanita, Deepak, and the rest of the IHRS team to give me this opportunity. This is definitely a very interesting title, to say the least. I feel like after that fantastic talk by Francesco, I am here having to talk about how do we temper some of the excitement he has created. So let's see if we can at least caution you guys to some of the things that you should be aware of. So this is just a beautiful figure that really highlights the evolution of some of the sites for pacing over the past couple of decades. And as you're well aware, we started off with RV apical pacing being the traditional site for conventional pacing, and have progressed to then RV septal, and now more traditional, more sites along the conduction system, which involve the His bundle, the left bundle branch, and deep LV septal pacing, as highlighted in this figure beautifully. So I think most of you are aware of this data. This is data on RV apical pacing, the most sub-study that really highlighted the risk of right ventricular pacing. And as you can see here with heart failure and atrial fibrillation incidence, the risk of heart failure hospitalizations and incident heart failure increased by almost 2.6-fold in this first graph in the dotted line, with burden of ventricular pacing over 40% and continued to worsen as the burden of ventricular pacing increased with time. The similar findings with incidence of atrial fibrillation, that with an increasing burden of ventricular pacing, the incidence of atrial fibrillation continued to increase. So that over time has brought us to hispondyl pacing, which you guys are all well aware of at this time. This was some of the early work that we published. Again, I have to caution you, most of the data that you are going to be seeing, as well as some of the data that Francesco already highlighted, is mostly non-randomized, either prospective or retrospective studies. So this was one of our first study, again, with Dr. Vijayaraman and Dr. Allenbogen, that we looked at hispondyl pacing versus RV pacing with an 80% success rate. These were early implants from back in the year 2010. And what we found to our surprise was that in that cohort of patients that were paced more than 40% in the ventricle, hispondyl pacing, as you can see in the solid line up top, did dramatically better than our right ventricular pacing, which was the dotted line on the bottom, with a statistically significant difference in heart failure, hospitalization, and incident heart failure. When we followed these patients for a longer period of time, we see that the cohort of patients that received hispondyl pacing had stable LV ejection fractions in follow-up, while the cohort that received right ventricular pacing leads demonstrated a significant decline in their LV ejection fraction. And again, as we're well aware, as the burden of ventricular pacing increased to over 40%, that decline in the RV pacing group was even more statistically significant. But there are some downsides, and we'll summarize this in a moment, but the need for lead revisions was about 6.7% in this cohort of patients that underwent hispondyl pacing. There was also a higher need for generator changes, although 4 out of these 7 gen changes were unfortunately because of a premature battery recall on a certain manufacturer, so that data is a little bit skewed. And interestingly, the one patient in the hispondyl pacing arm that developed a pacing-induced cardiomyopathy was a patient that actually lost his capture and had RV septal capture alone because of a inappropriately programmed output by a physician outside the facility. And when this output was appropriately increased, the patient's ejection fraction improved again. Again, a much larger study by Dr. Vijayaraman and his group demonstrating in a much larger cohort after gaining experience of implants for a few years, that the success rate in a much larger cohort of 332 patients was about 92% now. These were implants performed between 2013 and 2016, while as you saw in the first study, those were implants in 2010. And what they found here was, with a primary endpoint of death, heart failure, hospitalization, or need for upgrade to biventricular pacing, in all comers, hispondyl pacing did dramatically better than right ventricular pacing. And that difference was again more pronounced in patients that had a higher burden of ventricular pacing. This was a recent study that we published in JAHA. Again, looking at, we saw how hispondyl pacing does better than right ventricular pacing when it comes to heart failure hospitalizations, but this is looking at incident atrial fibrillation. In the study of 225 patients, we found that patients in the hispondyl pacing group up in blue did dramatically better than right ventricular pacing with incident atrial fibrillation, and that remained true no matter what the pacing burden was. This is 20%, 40%, 60%, and 80%, significant reduction in incident atrial fibrillation with hispondyl pacing. Again, Francesco already highlighted this study. This was a study looking at multi-center retrospective evaluation of hispondyl pacing for cardiac resynchronization therapy. And you can see a dramatic reduction in QRS widths, improvement in LV function and NYHA functional class, overall clinical response rate of 73% with a super responder rate close to 40%. The cohort of patients with right bundle branch block, which is a unique subset of patients, we found again an overall response rate of 76% with a super responder rate of 20%. So I'm sure all of this data is starting to get you excited. And then the final cohort of patients was patients with pacing-induced cardiomyopathy. As you can see, with his funnel pacing, a dramatic reduction in QRS width and a dramatic improvement in LV ejection fraction after revising these leads to the his bundle location. So with all of this data at hand, the current guidelines, as Francesco has already highlighted, recommend a class 2A indication for his funnel pacing against traditional bi-VCRT in patients with an EF between 36 to 50% and need for more than 40% pacing. Also a 2B recommendation for patients who have block at the level of the AV node. But there are limitations, and that is what we're here to temper the excitement about. And it's important to recognize these because you cannot take your first case and take the most challenging patient and hope to get a good result for that patient. There are challenges or limitations with this strategy. So unlike traditional right ventricular pacing or biventricular CRT, his funnel pacing cannot be successful in all patients where indicated for pacing or CRT strategies. There are technical challenges. There are challenges with the anatomy and the level of disease. So if the disease is truly intrahischian, it requires more experience to be able to map these areas carefully before you can implant a lead distal at these sites. If the disease is truly infrahischian, which is more distal, then his funnel pacing may not be successful irrespective. There are challenges with the delivery systems. We only have a couple of delivery sheets and only one lead, which was not truly designed for his funnel placement and implantation. And then there are challenges with experience, as you list levels of experience with a need for lead revision somewhere around 7%. And we'll come to why that might be the case, but those are performance related challenges with regards to the lead and this site. And then finally, as we've highlighted earlier, most of the data we have available at the present time are non-randomized and are performed at specialized centers with high volumes and experience for this type of pacing, and hence these results should be interpreted with some caution. And as you can see here, very beautifully highlighted by Dr. Vijay Raman and his group again, that the success rate between 2010, 2011, and 2013 dramatically improved with time, and the procedural duration and fluoroscopy duration decreased with time as well, as their center gained more experience with his funnel pacing from their early implants down to some of their more recent implants. So again, experience plays a big role, and you can imagine this is a center where majority of their implants, whether conventional pacing or CRT implants, are performed with conduction system pacing. And despite that, they still were only able to get to a success rate of close to 90% and decrease the procedural duration. So very important to keep in mind that experience and time does play a big role in getting higher success rates. We also talked about lead performance and how there is an increase in capture threshold by about 10 to 14% and need for lead revision between 3 to 7%. And what are the possible reasons for these? It could be inadequate fixation by implanters that don't have enough experience. Variable lead slack has been demonstrated by us in a few cases. Local fibrosis, and there has been some debate about disease progression. Micro dislodgements with time as the lead moves with the tricuspid annulus, and whether or not the current lead design with the steroid elution technology, it does have a role to play with increasing capture thresholds over time remains to be understood. So in order to overcome some of those challenges with threshold increases, Dr. Wong first described this technique of left bundle branch area pacing. And as you can imagine, based on this, we're going more distal down the conduction system. And you can see based on this beautiful anatomical specimen that the left bundle branch is a much bigger fan-like structure, allowing for a bigger target zone for lead placement compared to a very narrow cord-like structure that is the his bundle. And that might be an advantage in addition to the fact that you are placing the lead in the interventricular septum, thereby allowing for a much lower capture threshold overall. So again, here's a beautiful example demonstrating a lead at the his bundle with an A, His, and a ventricular electrogram, and a lead at the left bundle branch demonstrating a left bundle branch potential, followed by the local ventricular electrogram. And on the right-hand side of the panel, you see nice, beautiful capture of the left bundle branch with the right bundle, incomplete right bundle branch block type morphology. There is a lot of data that has been published on this topic. And this is a study by one of our very own Shanmuga Sundaram with basically highlighting all of the studies that have been performed to date, including the more recent one by Dr. Vijayaraman that Dr. Zanon already highlighted, which was in a CRT cohort of patients. But again, my job here is to temper some of this excitement. So I'm going to present to you some of our recent work. And this was a study that has just come online in circ arrhythmia and electrophysiology. And what we did was looked at our experience in 181 patients where we achieved a 98% success with conduction system pacing. And I want to make sure that I lay out the strategy, and we'll come to it in a couple of slides. But really what we did was for any patient that we were not able to achieve His bundle pacing with a capture threshold under 1.5 volts. And the reason for that being the higher the threshold at the His at the time of implantation, the smaller the safety margin if the patient's threshold increased with time. And also the higher the threshold at the time of implantation, the suggestion that there is still some disease distal to where your lead is. So for both of those reasons, we changed our strategy where we used a cutoff of 1.5 volts at 1 millisecond. Any threshold above that, whether or not it is even for bundle branch block narrowing, any threshold above 1.5, we would move to left bundle branch pacing as our bailout strategy. And so what we saw was that out of these 177 patients that were successful, only 120 patients were successfully implanted at the His bundle region, while the remaining required left bundle branch pacing. And here are the reasons, and we'll come to this in the next slide. So you can see here, again, this, to summarize, 120 patients with successful His bundle pacing, 57 patients with successful left bundle branch pacing. And here are the reasons for left bundle branch pacing in this cohort. High His capture threshold was 40%, which was the biggest reason. Failed recruitment of bundle branch block was another 30%. So essentially 70% of the reasons were failure of His bundle pacing to achieve the desired outcome. His bundle lead revision accounted for another 20%, which was about 5 to 7 cases requiring His bundle lead revision, in which case every patient got a left bundle branch pacing lead. We did not try to implant the lead back at the His bundle region in those cases. And what we found was very surprising. If you look at the lead-related complications, and I know that there are multiple studies that have demonstrated that these pacing modalities are very safe and we have good outcomes, it's important to realize that unless you're looking for some of these adverse outcomes, you're not going to recognize them. So macro lead dislodgement basically means a complete dislodgement of the lead. We saw that in 2 cases in our series, which was, and this is not intra-procedural dislodgement. This is after the patient has left the procedure room up to the first 30 days. And you can see that 2 patients had a macro lead dislodgement. Luckily, both of these were post-op day 1 while in the hospital and needed to be brought back in for lead revision. Micro lead dislodgement really means, and I'll show you an example of this, is that the lead has pulled back towards the RV side of the septum, resulting in capture of the RV septum, which may not be the intended result, particularly for those patients that need resynchronization therapy. And unless we're looking for this with follow-up ECGs at the time of device checks, you're not going to recognize this potential issue. And finally, we reported 1 case, which was the first reported case of an intraventricular septal perforation in long term. This was 3 weeks out, and I think I shared this case with some of you guys on one of our previous visits down in India. So here's the example, and this was a very tricky case, and the reason for that being, this lead, here's your interventricular septum, the lead perforated the interventricular septum and made contact with the posteromedial pap muscle. There was no change in impedance, there was no change in threshold on unipolar or bipolar, and these are the 3 panels. So this is the patient's baseline post-implant ECG with a nice QR pattern in precordial leads V1 through V6. This is his unipolar paced QRS, and this is the bipolar paced QRS. Now, if someone did not check in unipolar, just check bipolar, you would say this looks fantastic. It is exactly the same as the time of implantation, and that everything is stable. But when you check unipolar, you look at the morphology, you very clearly identify this looks like a pap muscle PVC morphology. That is what got us suspicious. We performed an echocardiogram, and you can see here very clearly the lead through the interventricular septum making contact with the posterior medial pap muscle. And we had to bring this patient back for an extraction or explantation of this lead after putting him on anticoagulation for a few weeks and implanted a fresh lead, and with the patient's request to be implanted again in the left bundle branch region, but with careful monitoring on echocardiographic imaging. And he's done well now, 1 year out in follow-up. Here's another example of what we were talking about. You can see here, this is the nice QR pattern in V1, but as you look at follow-up on the ECG in the same precordial leads, you now have what looks like RV septal capture with a left bundle branch type morphology, suggesting that this lead has pulled back from its original site to the RV septum. And for patients that have a routine pacing indication, this may not matter as much, but for a patient with a depressed ejection fraction where left bundle branch pacing is chosen as a resynchronization strategy, it is very important to look for this, otherwise you're not doing justice to your patient. So there are limitations with left bundle branch pacing as well, and those are, again, technical challenges. It may not be successful in every case. Challenges, we have challenges at the present time in order to better define what is true capture of the left-sided conduction system versus LV septal capture alone. There are challenges with anatomy if a patient has a history of a septal scar or disease is quite distal or intramyocardial. Challenges with the delivery system, and again, with experience. I think people believe that left bundle branch pacing is easy, maybe easier than his bundle pacing, but that does not mean that it is actually easy if you want to do it right for your patient. Issues concerning loss of left bundle capture, perforation into the interventricular septum, and there are a couple of more cases that have been now reported of this. Coronary injury, as you've seen, have been reported a couple of times now. And questions regarding extraction in the long term certainly remain unanswered. And again, just like his bundle pacing, we do not have randomized data when it comes to left bundle branch pacing, and some of these results should still be interpreted with some degree of caution. Again, this is a schematic that some of you have seen, but for patients with an EF greater than 50%, this is what our strategy is at the present time, is to start with his bundle pacing. And if the threshold is more than 1.5 volts at 1 millisecond, including bundle branch correction, we proceed to left bundle branch pacing. If that is unsuccessful, we will implant the lead at the RV septum. For patients with an LV ejection fraction less than 50%, it is very important to highlight that biventricular CRT still remains the gold standard. We're not recommending that this be first-line therapy unless you feel like a patient can be unaffording and only pay for a dual chamber pacing system, which is quite true in many parts of India. In those cases, you could consider his bundle pacing, again, with a similar cutoff for capture thresholds, move on to left bundle branch pacing. And for that cohort of patients that have multi-level block with an IVCD pattern, you could consider combining his bundle pacing or left bundle branch pacing with LV lead placement, which is referred to as hot or LOT CRT. So to summarize, his bundle and left bundle branch pacing, they have demonstrated a significant improvement in outcomes, particularly in patients with need for ventricular pacing and depressed ejection fractions. However, there remain technical challenges with successful implantation and challenges with long-term lead performance. With a better understanding of the reasons for some of these issues, improved and dedicated tools and experience, we could overcome some of these challenges. But finally, we need more randomized controlled data involving multiple centers with different levels of experience before some of these pacing modalities can become more mainstream for traditional pacing or cardiac resynchronization therapy. Thank you very much again. I will stop here and hand it over to Dr. Ellenbogen. Dr. E, I think you're still muted.
So you have to unmute yourself.
Thank you.
Yeah.
I've tried, Dr. Rohr, I've tried to keep up with the questions as they've been coming in. And one thing is very clear to me, there are a lot of questions, and you know you're reaching out and grabbing people's interest when so many questions, really good questions, come across. Some of them I could not even answer. So I'm gonna introduce the last speaker. I may have to leave part of the way through. So what do I want to make selective conduction system capture logistically easier? Vision for India. You have a hard job to follow. We've had two absolutely fantastic talks, but I'm sure this one will be great too. Dr. Ulhas Pandurangi will, from the Madras Medical Mission, will talk a little bit about where this field needs to go. Thank you.
May I add here, Parik, if you have time, will you address the questions for you on the chat in the meanwhile, while Ulhas is giving his presentation?
I will do my best.
Thank you. Ulhas, you have to go on the slideshow mode, please.
Yes. Vanita, thank you very much. Am I audible, Vanita?
Absolutely. Audible to everybody, not only to me.
You ultimately pushed me to talk about the Indian way, and what is the kind of a...
I pulled you, not pushed you. If I push you, you will fall.
Okay,
I'll pull you.
As Dr. Ellenbogen is moderating, and the person who actually ignited this passion, Parikshit Sharma, is there. It's such an honor and privilege to share this particular evening with all of you. Vanita, thanks again. And I'm going to be talking about Indian way of making conduction system pacing popular or logistically easier way. And Indian way is a Jugaad way.
You may have to explain what is Jugaad to Dr. Ellenbogen.
You think so? Okay, let's admit one thing. Most of the device implants in the country are by non-EPs, no offense. And Parikshit and the previous speaker, they said, we need to be adopting CSP, so we need to be making our implanters other than the EP guys to also to get into this so-called physiological pacing, because it looks like it is good. And it's our duty to make everybody, not necessarily us, but anybody who had been implanting the devices to embrace this technology, then only then it makes sense, I believe. And for EPs, there are more important arrhythmia issues to address. And for us also, this entire physiological pacing should also be made simple, because we know that when you get into this so-called physiological pacing, we are actually spending a lot of time there. We would have been done with, say, for example, CRT or the routine way of pacing, much earlier before. So now I think it is creeping into our time. So there are definitely reasons why this whole thing should appear simple, and it should appear less intimidating. Well, we are inspired in the last, about 8 or 9 years now. Every single day, we are inspired by the slogans of Atma Nirbhar Bharat. We got to be Atmanirbhar. We got to do something which people should look up to. And Vanita, this is the slide for Ellen Bogan if he's around. Jugaad is the most respected word, at least in my EP lab. Yeah. And actually this word is also adopted for everybody's information by the Oxford Dictionary, which is a flexible approach to problem solving that uses limited resources in an innovative way. We are all known for our jugaad ability. When we can afford a two-wheeler and put some money and buy a trolley bag, we believe it's a waste of money to go for a four-wheeler to carry the luggage. And this jugaad gene is embedded in our chromosome. It is just that we got to be making use of it when required. It is good to learn conduction system pacing, physiological pacing from experts like Vanita, Dr. Shanmugasundaram, Dr. Pugalendi, Parikshit Sharma. It's good to understand the longitudinal dissociation of the fibers. They're committed much proximally. There is the source and sink concept. Beautiful science. It's also very, very interesting and very, very intelligent way of imagining the conduction system on top of the routine fluoroscope. But the things become more complicated when you start explaining all this and the multiple catheters to the people in India who actually implant more devices than all of us who are attending this session put together. When I start talking about this science to them, they ask me, Bas, let me know his bundle pacing, where the lead is on the fluoroscope. Okay, show me where in RAO and LAO. And then when I put this is how it looks. In the RAO, in the LAO, in the his bundle pacing and the left bundle area pacing, these are the fluoroscopic views. Many become more excited. They think, wow, is that the way? Make them understand science is there. You do not have to really look into all that science, but at least in your lab, you have a monitor. Most of them do have, it's just they don't make use of that, where there's an ability to get 12 leads on the monitor. Don't expose the screw and pace at a higher threshold, or expose the screw few turns and pace. And as long as fluoroscopically it is appearing this way, and on the 12 lead, with or without pacing, the QRS is looking good to you, you are done. Because you should understand that, even with the greatest of the experienced people, to get the desired QRS width is just about 10 to 20%. If you really look at the end result of whatever the physiological pacing, it's still, the mean is more than 100 milliseconds, whether it is his bundle or the left bundle. So why are you looking at real narrow QRS, which is the result of the pacing? When I try to tell people that this is how the conduction system pacing is done, there is a lead there and you connect it to the EP system. And then you will have to use the jumper cable so that the analyzer, the device programmer could also be connected. When already there is a kind of an apprehension in them, how do you do this? The lead is there inside, you are talking about while screwing the lead, you are connecting it. How is that possible? So some kind of a fear is generated. And if I take them to the lab and show them this is how they set up, most of the people run away. This is too much of a complicated issue for a general implanter of the device in the country. It requires not only the implanter, his assistant, a scrub nurse, and top of that, a minimum of 2 people in the lab to look after all these connections. And most importantly, the connection has to be so great, the earthing has to be so great, your EP system and your recordings should be artifact free. It is a very, very difficult task to achieve. And hence, there comes Indian trade, jugaad. Let me show you some examples where nothing hi-fi, nothing extraordinary, making use of 2 tools which are available in the lab, where you can achieve really good results, making use of the stillets and making use of the workhorse deflectable catheter Agilis. I would like to show you a few examples what we have achieved with this and why it should be made popular. For example, a stillet could be shaped in exactly the same way what the Medtronic has provided the sheath for his bundle lead. You can create almost the primary and the secondary curve. You can make use of this. Now I'm going to show you how we can make use of the Agilis sheath.
This is a regular Medtronic's his bundle sheath, which is non-deflectable, and it has primary and a secondary curves. Oftentimes these curves turn out to be quite inadequate when you would like to fix the lead at an appropriate place. Now let me demonstrate how do we make use of used Agilis sheath in our laboratory to overcome the limitations of the available non-deflectable Medtronic his bundle sheath. This is an Agilis sheath which we have used it a few times during the epicardial ablation procedures. This is not that regular Agilis sheath, it's a shorter version of Agilis sheath, which is 40 centimeters in length. 8 French is the inner diameter. What I have done here is I have punched a hole on the surface, not through and through. This sheath is quite friendly when it comes to making curves. It's bidirectional, deflectable. You need to punch the hole with the routine gadgets available in the lab. Now I would like to demonstrate how do we insert the regular non-deflectable his bundle sheath of the Medtronic into the Agilis sheath, where I have created a hole. Take the sheath with the dilator inside so that it's easy to insert the sheath with the help of the dilator. The his bundle sheath with the dilator could be easily passed all along the length of the Agilis sheath. And once you remove the dilator and insert the lead, you can make use of the primary curve and the secondary curve of the sheath, and you can manipulate the Agilis sheath the way you want it, and it is possible to reach wherever you want to fix the lead. With the help of the Agilis sheath and his bundle sheath inside, it appears to me that I never could. Now I would like to demonstrate how do I make use of regular bipolar screw-in leads to perform the conduction system pacing. I convert the regular stillet into a stillet to have those primary and secondary curve similar to what we see with the his lead sheath of Medtronics. Now assume that you have taken the regular bipolar screw-in lead and you have inserted this stillet into the lead, and the pacing lead with the stillet inside. You pass through the punched hole here, and then once the lead comes out of this place, just keep the distalmost part with both the electrodes exposed and manipulate the sheath, and it's possible to fix it either at the his bundle or at the left bundle area.
So this is one of those stillet-driven DXAICD lead. Well, it is difficult to obtain the lead position in such a way that the R waves are great, and it actually appropriately detects the induced VF, etc. If you have taken care of that, it is possible with the stillet-driven lead like DXAICD can obviate the need for the multiple leads to achieve the CRTD. For example, in this particular case, the result was quite gratifying. This was the one where this patient was a secondary prevention of sudden cardiac death, severe LV dysfunction, with the stillet-driven single lead. We got some series of cases of this kind now, where you can achieve, this was the best of it. But, well, there were cases where the QRS was not so much, but then we took a risk. We induced the VF so that the R waves are sensed. We really looked at the R waves, and most importantly, we have counseled the patient that, look, this is an investigational, and then they participated in the program. This is a dual chamber ICD converted into the CRTD, just the stillet, and the result is good. So this is, I think, again, one of the few cases which I've been doing. Stillet-driven screw-in leads, it's possible. It requires a lot of patience. Of course, there is no EP system is required. It is just that all 12 leads are displaced, and screwing in and screwing out needs to be done. There is a small fear that if you do it multiple times, screw in and screw out, these leads are not made for too many attempts, but then jugaad we could achieve with the stillet, great physiological pacing. This is the stillet-driven as well as the Agilis sheath used procedure, where the Agilis sheath was quite against the septum. You could actually even inject a dye there, and your regular lead, any company's lead, it can get into the Agilis sheath, and you can actually do this way. And of course, there's a 12 lead going on. When you turn a couple of screws into the area, start looking at the changes of the QRS. Typically in the V1, look for the notches migrating from the descending limb to the ascending limb. Possible. It is absolutely possible, just that you've got to sacrifice an Agilis sheath, which is probably a few thousands costlier than his bundle sheath of Medtronics. But the lead is much more comfortable than the Medtronics. Oh, this was the result of that. So ladies and gentlemen, Vanita, thank you. Give me the opportunity to showcase what we did here in our hospital. I'm sure these are all experimental investigationals, but we have in record, we discussed with our patients, this is what we have been doing. I'm not sure whether it could be still contested. This, I think, it is ethics when we speak clearly about what we have been doing to the patient. Bottom line is, the conduction system pacing, physiological pacing is a great thing to adopt. We want all our implanter friends in the country to think about this. The system should evolve so that, no need for a EP system, no need for so many gadgets, just a 12-lead monitor, and the implanter is comfortable, and then try to achieve the narrow. What is physiological pacing? Ultimately, at the end of the day, you require a narrow QRS complex. So without an EP system, I think if somebody does this, it's great. And then if you are in a problem, think of India, think of Jugaad. Thank you.
Thank you so much, Dr. Ulhas. It was actually a very eye-opening Jugaadu lecture. I loved your ideas.
If somebody hates me
I have
this presentation, you bear the responsibility. I never wanted to show this to anybody.
Actually, it's Deepak's show. He has designed all the talks, so it is you have to pull his leg in case you want any kind of you have any sentiments of that. I have just one or two questions, and there are two questions on the chat also. So my first question is the ICD lead that you placed at the his bundle and narrowed the QRS. Were you able to get a good R wave there?
If you don't get a good R wave, you should move from there. If you get a good R wave, you are bound to induce the VF. So the choice of the patient is such that you should be able to induce VF. That is very important. It's not only just the R wave, whether the induced VF also was detected. We know the induced VF is probably different from the clinical VF, but it's okay. It's okay. At least you tried that. Actually speaking, I'll tell you something. In that particular first patient, we made him to come down the cath lab table. And we looked at the R wave. Because that R wave is probably the real world R wave, not the R wave when the patient was on the bed.
I agree with you, Dr. Ulhas, on this. The point I was trying to make is that the very concept of his bundle pacing, we know it is the fibrous part of the septum, where generally, in case you are at the actual his site, you will not get a good R wave.
True.
Right. So I don't want everybody to leave with an idea here that if you are using an ICD lead at the his bundle position, then if you don't get a good R wave, you get a good his position, but you don't get a good R wave. So you are good with that ICD lead. Then they should use some other strategy, not this jugaad which has been shown.
I am not asking anybody to adopt any one of my means. You told me to show what I have been doing.
Okay, your point is well taken.
Yes. So
now, I have a suggestion here.
I'm here to just show what all nonsense maybe I have done.
Okay.
I'm not here to recommend anything which I showed.
Your idea of edgeless sheath is actually splendid. It is a splendid idea. I loved it. I don't know why you showed it here. You should have had the patent to that. You should have had the patent.
Hold. That's not my original idea.
Okay, fine. But Dr. Saxena has a question there. He says, how do we remove the edgeless sheath after fixing the lead? So he's going to try it. I'm sure if he's asking this question, he's definitely going to try it.
Whatever is coming to his mind, the way he wants to remove it, he will remove it. Okay, so it's a joke, but you know what? It's the challenge of the whole technique there. I'm not sure whether I explained nicely in that hurriedly made video. You see, what is important is where you create the hole, where you punch the hole. That's most important. Make sure that you are creating the hole. So by the way, this is not science. Nobody should attempt this, please, and nobody should blame me. I just am saying what is happening. See, you create the hole as nearer to the distal tip as possible. That's rule number 1. You should have a friend of, you should be a friend of an orthopedic surgeon. You know why? Because you need a scissor, what an orthopedic surgeon uses to cut the ligaments. You got to get them, and each time you cut, there's a new scissor, which comes about 1,000 rupees or so. Don't make a jugaad there, the
Point
Egyptian
well taken.
will not cut. So all that. So you got to have a orthopedic surgeon using scissors to cut that, okay? And then you cut it. Achha, by the way, listen, there's one more thing here. If you have a his sheet inside that, it's okay. You can struggle with a reused orthopedic scissor or any scissor. But I showed you some leads. You got to be careful, because I'm not sure whether it damages the insulation of the regular bipolar screw-in lead. There, I think you got to have the scissors has two things. The inferior one, whatever you call that, it should be blunt. All things are you got to have that setup in your lab, basically.
Thank you. Parik, what do you think about Dr. Ulhas Jugaad? In your
Yeah,
experience?
so a couple of quick comments. I mean, I think they're both very, very fantastic techniques that Ulhas you've worked on and tried. We certainly wouldn't be able to try that here in the US. So I think that someone has to. So I think it's a good idea. The couple of things that I would be worried about, of course, and you've highlighted that this is not something you're recommending. This is something that you've tried on a few patients. And I think we should probably work on putting that together, because if it works well, then this will create opportunities for future development and newer tools that can help us minimize. There is actually one lead that is in development for defibrillators based on that exact idea that you presented. But there are 2 points to that. One is I would certainly not recommend putting it at the his bundle. One, because majority of that coil will actually potentially sit back on the atrial side, and you don't have control over that as the patient moves. Will that really, even if you leave the slack in the ventricle, what happens when the patient stands and the slack moves? Then the defibrillator coil ends up on the atrial aspect of the tricuspid annulus, and that will not be successful with defibrillation. So I think the left bundle branch pacing may be a better strategy for a defibrillator lead if you were to try and implant it, because you're more likely to get good sensing for R waves in the septum, and the lead's probably going to have more ability to have myocardium that it can successfully defibrillate. On the flip side, I also worry that a lead in the left bundle branch region, especially if it's a defib lead, will it be stable? Because as you guys who have done left bundle branch pacing are well aware, the septum really is like paneer. I mean, it really, once you get in through that RV endocardium to get to the LV endocardium, it takes you 2 or 3 or 4 turns sometimes. So is the lead really stable there when it is that big of French size for a defib lead? We don't know the answer to that question. And that's why I think data from you, Ulhas, would be really critical going forward to give us that information. Because if that is the case, we could definitely study this in more patients. So that's when it comes to those two. When it comes to, again, extendable retractable leads, that again is something that has not been studied. I've done a lot of implants in animal models and perfused heart models. I've done few patient implants, but we don't know the long-term performance of these extendable retractable leads as compared to the 3830, and they might be better, but we just don't know the answer. So again, I worry with 6 or 7 French pacing leads compared to a 4 French pacing lead. How do those leads perform in terms of stability at some of these areas as well? So stability and long-term performance, but that needs to be answered. So maybe as we're trying to get some of these answers, we'll be a little bit careful about doing these in patients that are completely dependent, but otherwise it should be reasonable to try. And finally, that Agilis was fantastic. I remember I did a case in Mumbai. This was not as part of one of the proctorships with a cardiologist who wanted me to do a his bundle pacing implant for one of his relatives. And we got a beautiful result. It was a right bundle branch block that we narrowed with the C315 sheath. And as we were slitting it, the lead dislodged. So I asked the Medtronic rep for another sheath, and they said, we never carry more than one. And the next sheath is 4 hours away. So so this was actually a day where I was supposed to buy 1 day off, where I was supposed to spend some time with my family before I flew out that same night. I said, I can't wait 4 hours because I'll get killed at home. So we actually took an AL2.
Wow.
But the challenge with a lot of these sheets is this ability to slit it, like you highlighted. So what you really have to do is to be able to make a cut in the sheet somewhere. And then it does take a lot of force, but at the same time, you have to make sure you maintain forward pressure on the lead so it doesn't pull back as you're slitting the sheet. So these are not easy to do. They're not something that, even just like Dr. Ulhas said, we don't recommend until we have some more experience with it, and certainly not for those that are doing their first implants. But definitely for these Jugaad type cases, these are good strategies for those patients that are unaffording or don't have other means to be able to pay for things that we're not able to get them. So thank you. Those were brilliant cases. I appreciate it.
Parikshit, I have Vanita,
Yes,
can I
Dr.
ask one question to Parikshit?
Absolutely, sir. Please.
Parikshit, Ulhas raised a very important question that, a majority of implanters in India cannot, even I as an electrophysiologist, sometimes it's tedious, when you have 2-3 cases waiting and putting everything together. But I can imagine for a non-EP cardiologist, if you tell them to do all this, they get put off. So in the US, in the real world, now that physiologic pacing has been there for quite some time and you all have been promoting it, what is the real world situation in the US? How many, when indicated or when it would be useful, are doing the physiologic pacing, and how many are just doing the conventional RV
I
pacing,
would
maybe
still,
RV?
that's a very good question, Dr. Yash. I think despite everything that we have shown and despite all the enthusiasm and excitement around this new area in pacing, I don't believe more than 50% of the US EPs, not general cardiologists, EPs are still not performing conduction system pacing. So to expect a general cardiologist who doesn't even look at electrograms to suddenly start doing his funnel pacing and or left funnel branch pacing, I think is a little bit far-fetched, at least at the present time with the current tools we have. It's just like saying, if we were to take, a lot of all of you guys who are, like my mentors have actually seen the era where we started doing coronary sinus pacing for the first time. Right, so that has evolved from its original days of just dual or bipolar leads, which were much larger in caliber, now to quadrupolar leads with so many more tools. And I think if we have the right motivation and if we systematically study this, that is where we think that this field of conduction system pacing is headed as well, that there will be more development in tools and techniques. And that is when I think the general cardiologists can start considering some of these, because we'll make it simpler. We might have, the PSA be able to tell you if it's picking up a potential. The PSA and the device itself will be able to differentiate between selective and non-selective capture, simplify follow-up, simplify implantation. But until we get there, and in the meanwhile, we're also waiting on a lot of the real-world randomized control data. So as all of this evolves, that is when I believe that we will get to a point where most EPs and general cardiologists may start considering this as a primary therapy for their patients, but we're nowhere there. So.
Thank you so much, Dr. Sharma. Thank you so much, Dr. Ulhas. You really made us more bent towards doing his bundle pacing today. Although we know the pros and cons, we do understand that, but we know the jugaad also now. And I hope more and more people start doing physiological pacing. And please, but do not give up CRT. I know we didn't have Angelo's talk today, but do not give up CRT wherever it is rightly indicated. So with those words, I thank you all for joining us today, and see you next week. Take care. Good night. Thanks, Dr. Sharma.
Thank you,
Thanks,
everyone.
Dr.
Thank you,
Ulhas.
guys.
Bye, Dr.
See you
Yash.
soon.